Welcome to the next episode of Endoscopy Essentials. I'm very happy that my old friend Horst Neuhaus is here. Welcome, Horst.
Welcome.
And we have a very special topic today, which is resection of papillary or ampullary adenomas called ampullectomy. That's a sophisticated and dangerous procedure in an hysteric organ like the duodenum, right?
Yeah, absolutely.
So how do you start? I mean, how do you prepare for it? Which type of snares do you take? What's on your table?
Yeah, firstly, I think it's important, as with other therapeutic interventions, to start with an appropriate diagnosis, to select patients correctly. And in terms of papillectomy, I just show this first slide here. So as endoscopists, we do a papillectomy, whereas surgeons proceed to ampullectomy, which involves the muscularis propria, needing a reinsertion of the pancreatic duct and of the CB. So our approach is limited to the papilla, and therefore indications, as you said, are adenomas with maximum high-grade dysplasia, maybe in selected cases with early adenocarcinoma, and subepithelial lesions, so small neoprine tumors, for example, carcinoids.
Well, when I see this, Horst, should the aim be to go as deeply as possible with endoscopy, or be more careful, or move the border a little bit more towards ampulectomy, or what's the risk benefit?
I think there is not a real difference to EMR or ESD in the upper and lower GI tract. So we should be close to the muscle layer, but protect the muscle layer. And of course, the papilla itself is removed so that no neoplastic tissue is still around the papilla. So this is the first step. So we should exclude cancerous lesions, which can be identified by histology. Ulceration, when the lesions are not movable, this is always suspicious. And when patients are jaundiced, so when there is a substantial cholestasis, this is always suspicious for cancer. And now many ask, is it necessary to do any pre-operative diagnostic investigations? I think it's recommended to do EUS and maybe even better MRCP to rule out deeper ductal infiltration, and also MRI, and also experienced endoscopist with EUS, we can identify patients with a pancreas divisum, and this is helpful because then we know that there is no need for prophylactic pancreatic stent after papillectomy. So it's recommended, but it's not a must to do pre-interventional imaging.
I'm a little bit skeptical about EUS. Of course, everybody is doing EUS when we have a suspicion that this is big and maybe hard, so we want to confirm this. Yeah. But I remember many cases, even with smaller adenomas, everything looked perfect, small ducts, and then after ampulectomy, a small part came out of the bile duct, very small one. So yeah. I think it has its limits.
Yeah,
especially with minor infiltration of the duct.
Yeah, this may be an overstaging in some cases. But on the other hand, when there is especially when patients have signs of cholestasis, then we should do an MRCP or EUS.
The interesting question is always, what do we not do? Or do we say, okay, there might be something in the duct, but let's try. The patient is old and we want to avoid surgery, etc., etc. So.
Now, when there is any suspicion of cancer, when there is an ulcer, when the lesion is not movable, and we see substantial distortion of the mucosal and vascular pattern, then we shouldn't do it. We should then, in these cases, we should take biopsies, and if it's cancer, then these are either candidates for palliation or for surgery.
That's right. Sorry to be insistent, but you more rely on the endoscopic aspect,
yes,
right?
Yes, that's true. Yes.
So if it's endoscopically resectable and EUS is, then you would do it?
Yes, I would do it.
Okay,
yes. Yeah.
Thank you.
Okay, let's assume we have such a case here. This is obviously a papillary tumor with a size maybe of approximately 1.5 centimeter, then we should not inject, because by definition we cannot lift the papilla. The papilla is connected to the PD and to the CBD, and this makes it even more difficult finally to resect. And the randomized trial showed also that the zero resection rate is lower. So we should just proceed to snaring and resection. And I don't perform ESCP before papillectomy.
It's another very important
Yes.
message, because there are recommendations to inject blue and this and that to find the pancreatic duct, but you don't do that.
Yeah, okay, this can be considered from this point of view. So some inject blue indigo carmine or methylene blue into the PD, which may facilitate to identify the pancreatic orifice, but I don't do it on a regular basis, because usually we can see the PD orifice after resection.
So,
And ESCP is not necessary, because especially with pre-investigational diagnosis, EOS and MRCP, we know the anatomy. So there's no need to inject to increase the risk of pancreatitis.
so it can be summarized in a message: don't mess with the resection. Don't
Yes.
do anything which makes the resection more difficult.
Yeah, exactly,
Yeah.
exactly. So therefore, we can directly proceed to resection, and I usually use a monofilament snare, but braided snares is also fine. It depends finally on the setting of the electrosurgical generator. And it's always, nearly always easier to position the snare firstly above the lesion. So we push the tip of the snare against the duodenal wall above the papillar or the neoplastic area. And then we slowly open the snare, advance the duodenoscope more deeply into the duodenum, open it more and more, so that we finally can approach the distal part of the papillar, and then we ask the assistant to close the snare tightly.
So snare above, push down,
Yes.
better than snare below, and try to lean
Yeah,
against the
yeah.
papilla.
This is much more difficult, and more difficult to control. And so closing the snare, what I just mentioned, requires that the endoscopist opens the elevator and the assistant closes the snare tightly, because otherwise, when it's too loose, when you have not enough traction on the snare, then it does not appropriately cut. You have a lot of coagulation and thermal effects, which we would like to avoid.
Horst, I love these two pictures. The big question is where to place the snare on the left side. Is it just around that lesion, seeming lesion base, or higher up, encircling also normal mucosa?
Yeah, it should include the normal mucosa, because especially in this case, the mucosa looks quite normal here, but we see the bulging. So it's very likely that the adenoma is growing underneath. And therefore, I would push the tip of the snare here at 11 o'clock against the duodenal wall. And then, as I mentioned before, open it slowly and close it, advance the scope, close it tightly. More or less strangulation of the polyp,
Right.
which gets then bluish, showing that you have it
But that's
well entrapped.
very important, especially for beginners, because I think many people are afraid and they
Yeah.
would like to resect what you see here and the normal mucosa stays. But then you have the problem of residual tissue.
Yeah, yeah.
So when the bulging starts, right, there is the placement of the snare.
Exactly. And as you can see, the snare is in a tangential position to the duodenal wall. So therefore, there is no risk here to entrap the muscle layer. So perforation is, of course, the worst scenario, but this is extremely rare. Bleeding can, of course, occur. This depends from many factors.
Can I ask another question? So you push in, right?
Yes.
But then when you have encircled the lesion, you pull back, I guess.
Yes.
Yeah.
You
Okay.
pull back, and it's not necessary to jiggle. So many endoscopists always jiggle. I think sometimes they are a little bit nervous, but in fact, it's important to close it and then to pull, because the cutting, the sequential cutting, this is now done with the electrosurgical generator using endocut. It's important, however, that the tip of the snare is not still pushing against the duodenal wall, and you start with coagulation. Then you can induce deeper thermal injury of the wall with the risk of delayed perforation.
But don't keep this pushing position when you cut.
No.
Right upper picture.
Yes, yeah.
Pull
you
back.
pull, and then the next question is, of course, which kind of setting. This is a challenging topic. I think it's very much depends on how much tissue you have within the snare. So on one hand, we don't want to have a bleeding, of course. That means we would like to increase the effect. So the higher effect, the more coagulation, and also to extend the cutting interval with endocut. So the longer the cutting interval, for example, 6 is cut, 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 you have a lot of coagulation. This is nice in terms of the risk of bleeding. On the other hand, it may increase the risk of post-papillectomy pancreatitis, and therefore it should be something in between. So for this lesion, I would choose something like effect 2, and cutting duration 2, and cutting interval 4, and close the snare tightly. Then it cuts still quite quickly. But once it doesn't cut, for example, when you have a neuroendocrine tumor and you partially doesn't cut, then it's always a suspicion that the part of the tumor is inside. Then you have to shorten the cutting interval to 1 or 2. Then it's cut, cut, cut. Then the coagulation period is much shorter.
And then you come up with those nice pictures. So there's no adenoma. You see a little bit swollen mucosa around, and you look right into the ducts.
Yes. You look into the duct. Of course, I selected a nice image. It's not always so easy, but usually we can easily identify the biliary orifice, which is here. And then we're looking for the PD orifice, which is in most of the cases below at about 5 o'clock, as we can see. And then the studies show this. It's a longer discussion, a small randomized controlled trial and retrospective trials show that the risk of post-ESCP pancreatitis is to some extent lower with a prophylactic stent. This is also part of the guideline. And therefore, I insert a hydrophilic guide wire, even straight or angled, into this orifice here. And then I ask the assistant to advance the wire forward without injection. I follow it under fluoroscopy, and when the wire makes the correct direction, suggesting that we are in the pancreas, then it's no need to injection, just to decrease the risk of post-ESCP pancreatitis.
But you do it in any case, because there are people claiming, without evidence of course, that if you have a gaping orifice like this one, a stent is not needed. A gaping pancreatic orifice.
Yeah,
but we don't know.
According to retrospective and to this randomized control, the risk is lower. So this is just what means wide opening. Probably they are right, but there are no studies to prove it. But what I think, when you fail to identify the PD and it takes you more than 5 minutes, you cannot find the pain, then I would stop, because as you mentioned, the data are not so convincing, and finally you may increase the risk of pancreatitis just due to the manipulation.
I think there are some retrospective data telling that those patients are worse off in whom you don't find the pancreatic duct, despite maybe too long a manipulation.
The best scenario is when we know it's a pancreas disease, and then we can stop at this stage.
Can relax.
So this is here the end of the procedure. We place here usually a 5 French stent without proximal side flaps. So this migrates spontaneously in 90% of the cases. But patients have to be followed to reconfirm that the stent passed. Otherwise, it has to be removed. So stent should not be left in the pancreas for more than a week in a normal pancreas. Or still, I think, under investigation is to use a biodegradable stent.
Any stent form preferable, straight versus single pigtail?
Yes, I would recommend a single pigtail.
Okay.
Because of avoiding the risk of migration into the PD, which is always a major problem. Yeah. Okay, so this was an easy case. Now, this is now a stop in between. This is obviously a lateral spreading tumor involving the papilla, so an LSTP. And again, before we consider resection, we should try to demarcate, which is usually not so difficult, the lateral extension. And it can be difficult to identify the biliary and pancreatic orifice, but in fact, it's not really needed. So also in this case, I would directly start with resection.
Nowadays, maybe it's a sidetrack, but it's a relevant question. Nowadays, there's cold resection as well, which has been suggested to have a much lower complication rate, but it may be that the recurrence rate is higher.
Yeah.
If you do that, the papilla is still resected hot. So you start with the duodenal part first, and then if you can identify, leave the papilla.
Yes. And then
for the end.
Yes.
No matter whether all is hot or it's cold first.
No, I do it all hot. And as you know, the Australian group recently published a trial comparing a historical cohort with an actual cohort, with a prospective cohort, comparing this hybrid technique, so hot resection of the papilla plus cold resection of the lateral part with a conventional hot resection of the whole neoplastic lesion, and there was no significant difference in terms of bleeding, although the study was not powered for that. But what's important is that the study showed, and we have similar results, as you know, also in the colorectum, the recurrence rate was substantially higher. I think 39% recurrence rate with a hybrid technique. So therefore, we cannot recommend this combined technique.
Yeah, it's a trade-off, I think, between complications and recurrence, and the files are not closed, but recurrence is a significant issue.
But in this study, they had also a substantial rate of bleedings, even with a hybrid technique. Firstly, as I said, diagnostic evaluation, we can nicely delineate the lateral margin, and then, as we discussed before, we start with conventional piecemeal resection, submucosal injection with some indigo carmine to have a dyed submucosal layer, and then we push the tip of the snare into the normal part of the mucosas with some safety margin.
Same principle, start
Same
from
principle,
above.
Yes. And then again, we close the snare tightly and use endocut 2 to 4, and we harbor the specimen. So we can just leave it in the duodenal bulb. We can remove it into the stomach to save some time.
But you should do it piece by piece, not just resect, and then collect the remaining specimens.
No. Yeah. Although in such a case you don't need all specimen, because there will be no cancer here. So now we achieved complete resection, as we can see, and this, I go back to show it again. So I use a hydrophilic wire with a hydrophilic tip here. This is a Terumo wire, and ask the assistant then to advance it slowly forward. So I wouldn't inject here, because you can easily, in this vulnerable tissue, you would easily induce an edema, and then it's getting very difficult. So here's probably the biliary orifice, and there is no need, if the patient has no signs of cholestasis, no suspicion of CBD infiltration by EOS, there is no need to cannulate the biliary duct.
We have seen some secondary strictures, not many. So in the meantime, we try to cannulate if it's not too difficult, and then
you can do all
wow.
this. Now, fluoroscopy showed that the virus in the duct, if you cannot advance it easily, then you should switch to an angulated duct stent, because this minimizes the problem that the tip can advance into a side branch. So, and then here we place a biodegradable stent, 6 French, 5 centimeter, fast degrading. So starting at 11 days. So the advantage is that no further follow-up is needed.
If you look at the resection site here, do you anything preventive against bleeding, or is it useless or only dangerous?
Nobody knows if it's useful or useless. So if I don't see a spurter here, an ongoing bleeding, then I wouldn't proceed with electrocoagulation or whatever. Of course, we can consider to use a hemostatic powder, but I'm not so convinced that it really prevents the rebleeding. So if there is a mild bleeding and we cannot identify the bleeding site, then I would use a hemostatic powder. With electrocoagulation, we should be very careful because of the risk of deeper thermal injury involving the muscle layer. If you consider it, then I would inject first to lift, and then you can burn a little bit.
I think that's a very good idea, because you have a better visibility, and if you use the blue solution, it's better discernible. So okay, but be very careful. The duodenum is a hysteric organ.
Yeah. So, and there's also, we have no data to know what we use with the STSC, with snare tip coagulation, if it's needed in the duodenum. So I don't do it, provided that we don't see any remaining adenoma here. So this worked well, but now I show a bleeding. So also successful papillectomy, and I harbored the specimen on block resection. Histology finally showed also R0 resection, but I just removed the specimen and reinserted the endoscope and see this kind of bleeding here. So the question is what to do. So this here is an ongoing bleeding, and firstly I try to place a pancreatic stent, which is difficult because we cannot even not identify the area of the papilla. So therefore I inject first with diluted epinephrine to get an edema, so at least the bleeding temporarily stopped, and then as fast as possible I try to place a pancreatic stent. So I'm carefully probing here the area where I think the PD orifice is located, and then I place a 5 French here with side flaps because I would like to minimize the risk of migration during further manipulations. So, but only 5 French. The bleeding is ongoing. Now we can do electrocoagulation. So as mentioned before, I coagulate. So in this case, I also place the biliary stent, because once we inject a lot and manipulate, then you can also block the CBD. And still ongoing, so we place here a clip, which is sometimes difficult. So it's very important to straighten the tip of the endoscope, to insert the clip catheter outside of the scope, and then to open, not to break the distal part with the elevator, and then to come as close as possible to the identified bleeding site. So the bleeding could be stopped. So in this particular case now, I use a hemostatic spray here, hemospray, to minimize the risk of delayed bleeding.
Well, I think often there can be nasty bleedings, not severe ones, but they go on a little bit here, a little bit there, and you have you have to avoid that it looks like a battlefield at the end.
Absolutely, and this is also a challenge sometimes for the fellow who sees the patient at night after papillectomy. So we shouldn't do these procedures on a Friday. Because this is really challenging. When you rescope the patient and there is a diffuse bleeding, it's very difficult to identify the bleeding site. And we just mentioned we shouldn't coagulate too much because of the risk of delayed perforation. We flush, we try to identify the bleeding site. We can use clips, but also with clips we have to be careful, because as with regular spontaneous sporadic duodenal adenoma, the wall is very thin, and when we use especially a large clip, then you can even cause a perforation. So I wouldn't recommend a large clip, but smaller clips. And of course we have hemostatic sprays.
So you're right, targeting is more difficult, placement is more difficult, it's more risky. It's a very nice combination.
I don't show you only the nice cases, but also the ugly cases.
That's why we are here.
So in this particular case, we achieved a nice resection, but then we see here tissue coming out of the resection area. And in this case, I would recommend to combine papillectomy with sphincterotomy, but of course to cut as much as possible to the upper part. And then we see some tissue coming out.
This is what I mentioned before, because I bet this could have been an endosonographically negative case.
I agree.
These little remnants.
Yes. And what you can do is to use a balloon catheter to inflate it in the mid portion of the CBD and to pull this neoplastic tissue out of the duct. This is an option, and then to snare it.
Quite a bit, huh?
Yes. So, big problem are recurrences. And even with the best techniques, we have to consider, according to meta-analysis, recurrence rate between 15 and 20%.
At least.
At least.
I think it depends how carefully you look, whether you biopsy or whether you do it clinically, patient not jaundice, everything okay. Huh?
I agree. So my recommendation is after papillectomy, patients stay at least over one night to identify those with a delayed bleeding. And then we wait for the histopathology, of course. If it shows cancer, then most of the cases have to undergo finally Whipple resection, because surgical ampullectomy is not enough from an oncological perspective. It has to be combined with adenectomy.
It has a recurrence rate too, by the way.
Yeah, exactly.
Even for adenomas.
Exactly. So in some patients, in elderly patients with comorbidities, and the histology showing just submucosal cancerous invasion, you can consider and wait and see policy with a close follow-up. But otherwise, in case of adenoma, even with high-grade dysplasia, we follow the patients after 6 months. And here we see a recurrence. This is the typical whitish tissue around this scar after resection. Here is probably the biliary orifice. Yeah, how to deal with that? So firstly, again, I would recommend to place a pancreatic stent first, and then you can coagulate. You can use APC or large forceps combining with snare tip coagulation. So there are several options. So mechanical removal, as we do in the colon, plus coagulation. And in addition, I also use balloon dilatation to open up the CBD and place quite often then a fully covered metal stent to keep the lumen open. And then we follow the patient again after 3 months. Here we even combine it with cholangioscopy to exclude a deeper ductal infiltration, and the patient had recurrence again, and we used electrocoagulation. So these are the techniques. Of course, radiofrequency ablation is another option. Shows quite promising results. So for those who have an infiltration of max of 1 centimeter, especially in younger patients, those with deeper invasion than 1 centimeter should usually undergo surgery.
Right, but it's not infrequent that there's a small recurrence and again a small recurrence, and you always wonder, is it worth treating or what should you do? So I think it's a bit underreported.
That's true.
Yeah.
This particular this particular patient come for 20 years. Comes every 1 or second year. Of course, I recommend it as an alternative surgery, but the patient said, why should I go under surgery with such a small benign lesion? So he accepts reinterventions.
Yeah, it can become a chronic disease.
Yeah, that's true.
But I also agree with you that you should be moderately aggressive, placing stents, and then you can ablate the distal bile duct, maybe aggressively, and then place a metal stent. So you have the compression effect, etc.
The compression effect, and when patients come for the next follow-up, you have a nice view into visibility. The CBD and can easily manipulate.
Okay. So this was a very nice introduction into a very, very complex area. I appreciate your honesty with regards to complications, recurrence. So it's a difficult area. I think we can prevent most patients from getting cancer. But sometimes, as you mentioned with the last patients, it's sort of a palliative treatment.
Yeah, that's true. It's always a discussion with the patient and should be discussed in the multidisciplinary setting.
Okay, Horst. Thanks very much.
Thank you.
We hope to see you back for other topics.
Yeah, thank you. Yeah.